repeat again, PLAB will not cover those ethical things. Actually, those of you who have that blind idea, the PLAB will cover everything. It is not actually. Even a lot of questions, even last time those doctor went for exam is February, November, they say from our course there is more repetition, especially if you are doing the whole 5 years actually. So try not just targeting just this 1-2 months. We have been already giving you 5 years, so you should try finishing all those things actually. So I won't take much time, so I hope so you like that. So I'm just keep telling this, these are very important things we have to remind you. So thank you so much, Dr. Suman. You can keep it up. Good luck.
Okay, so I think today is the third class of PLAB 1 recall. Before starting my class,
fourth class actually.
Oh, sorry,
Yes.
fourth class. If I include the ethics, okay. So if before starting the class, actually, I want to discuss some important topic regarding PLAB 1. Before approaching to the exam, you have to revise some most important topic. But what you will revise, like before the exam, like 7 days before, what you will do, most of the times the students actually they are a little bit panic because they have very less time for revision. So the main focus of PLAB 1 to read about the investigation and the management plan. Okay, eventually like when you were an intern doctor, okay, in the past year, all of you have done your internship. So on that time, that clinical knowledge will help you for the diagnosis. In case of PLAB 1, they usually don't give difficult diagnosis part. But the problem is they want to know about the stepwise approach to the patient, like the initial investigation, like the definitive investigation, like the initial management and the definitive management of a particular disease. So I think for me, I had very less time for PLAB 1. And on that time I took some suggestions from seniors and those who have recently passed the PLAB 1 exam. I took their advices, and from that advice what I got, that is you have to read important topics fast and revise them again and again. Okay, so in recall actually we always try to include the most important topics and most important questions. And please remember one thing, like the whole PLAB 1, if you want to categorize the whole PLAB 1 exam, you can categorize it like this way. There will be 50 to 70% question regarding investigation and management plan, 20% question will be diagnosis, and 10% actually I will say extra like ethics, like anatomy, and there may be some direct question that is you have to memorize, okay, from different topic like cardio-neurology. Maybe that is not understanding, okay, you have to memorize the question like a landmark, like the dermatome of the hand, this type of question. So the purpose of today's class is to focus on that particular side of PLAB 1, that what should you read before your exam, how you will revise your topics. If you have less time, if you have more time, but start with the important things first. Like if you want to read rheumatology, start with rheumatoid arthritis or SLE, but don't read everything. Read the management, read the investigation, and see the clinical feature for once. Then you start solving question. Eventually, you will find out that what are the important topics of rheumatology. So, in every system, it is wise, it is advisable to do these things. Go through the important topics. Okay, now I will start my class and I will present some questions of previous recall batch, and I will give around 30 seconds for each question. I will suggest everyone, if you don't know, if this question is very unknown or very unfamiliar to you, I will suggest you to try and drop your question in the chat box, whether it is A, B, C, D, and I will discuss it with explanation. And if you have any confusion regarding my explanation, you can ask me directly. I will try to answer within this short time. Okay, so I'm starting. So this is our first question. Patient with puffiness of face and rash showing coronal spot on fundoscopy. What's the diagnosis? One is macular degeneration, B hypertensive retinopathy, C diabetic background and polyphatic diabetic retinopathy, and E is SLE. Okay, give me notes. Okay, I have found this question. Actually, I have found this question from uh, a Facebook group, because in last recall session they have given a question regarding SLE, about the diagnosis. And for me, actually, this question is a little bit incomplete, because the answer is, actually the answer is, you guys can see the answer is SLE. So in case of SLE, you will find facial rash. Okay, you will find puffiness or facial rash. Actually, that is a butterfly rash. The distribution, we always say the distribution is butterfly distribution over the face, and usually it spares the nasolabial fold. Okay, just try to remember, like in case of girl, even in the boys, sometimes we get allergy in from dust, from food, or like he or she is atopic person, and there is a facial rash too. But the characteristic of SLE rash, two important things you have to remember: the rash is butterfly distribution, and another important thing is it spares the nasolabial fold. So I think this question should they should give a little bit more elaboration in this question. Like they should give a patient has presented to you with facial rash for the last 2 months. Also, she's complaining of a little bit joint pain. Okay, and she also complained of uh, maybe shortness of breath, or maybe chest pain because of pleurisy, because sometimes SLE involve other organs too. Okay, so they have given one sign, that is cotonolar spot. And wherever I see, all of us, whoever, not me actually, even at first glance I thought it was diabetic background or polyphatic diabetic retinopathy, but then I recheck the other keys. When you are solving a question, try to collect the main important point in a single question. Like here, will find puffiness of face and rash. This rash is not going with the diabetic background or polyphatic diabetic retinopathy. It is more consistent with SLE. So the answer is actually SLE. Okay. So there are some diagnostic criteria of SLE, like you can remember this with this mnemonic. Give me just 1 second. Okay. Like soap, serositis, pleuritis, pericarditis. I'm just discussing these things. That sometimes the patient will present to you with facial rash, chest pain due to pleurisy or pericarditis. Maybe she will exhibit oral ulcer. Okay, joint pain, arthritis, photosensitivity. That means this rash will aggravate during sun exposure. Okay, and also there are some other feature, but just try to remember the soap. Okay, serositis, oral ulcer, arthritis, photosensitivity. These are enough. If you guys have any confusion, you guys can tell me that at any point. Okay, this question actually I don't like, and truly speaking, during this time, while I was preparing the recall slide, I faced a lot of problem, because most of the questions were incomplete. Okay, here we will get some information regarding SLE, systemic lupus erythematosus. I need to zoom this slide a little bit. Okay, it is much more common in female. Onset is usually 20 to 40 years. You have to remember another important thing, that is association with HLA. Sometimes they can give you this question: the systemic SLE is associated with which HLA? And you have to memorize this. There is no mechanism to understand this thing. Actually, you have to memorize these things: HLA, B8, DR2, DR3. Okay, but the most common part of SLE, and even in the previous recall, they actually ask the question: what is the most sensitive antibody? What is the most sensitive antibody of SLE? That is ANA. or they will flip the question like this: what is the most common antibody you will expect in SLE, that is ANA? Most sensitive and most common is ANA, okay, and most specific is anti-DS DNA, that is anti-DS DNA is double stranded DNA. It is highly specific for idiopathic SLE. Also, in the option, if you don't get anti-DS DNA, then the second option is anti-Smith, okay. And please remember, in SLE, the complement level is low during active disease. Actually, the complement level is low, like the C3 and C4. But which one is low? First, like a patient is taking the treatment of SLE for a long period of time. Now it is under remission. Suddenly, there is relapse of the SLE. What will happen? There will be, first, the C4 will be low. Please remember which complement level will be low at the beginning of active part of SLE, that is C4. Then the monitoring part is very important in SLE. Actually, the ESR remains high, but CRP usually normal in active part of that disease. If CRP is high in a patient of SLE, that means there should be an underlying infection, and we should search for that kind of infection. Maybe we should do blood culture, urine culture, depending upon the clinical scenario. Okay. So in SLA, we should do ANA initially. If it's an option, then DNA based. Okay, like it's not like that. Actually, they will give you a question that most common or most sensitive marker of SLA, that is ANA. Most specific, they will ask for most sensitive. After most sensitive, they will ask for most specific, that is anti-DS DNA. But if there is no option in the question, like there is no option like anti-DS DNA, and if the question asks for most specific, don't go for ANA. ANA is most sensitive and most common. Anti-DS DNA and anti-Smith antibody is most specific antibody. Okay. Sometimes some drugs are responsible for systemic lupus erythematosus, and that is known as drug-induced systemic lupus erythematosus, and in that case you will find anti-histone antibody. Okay. And for SLE, also you need to know two other information in SLE. Actually, all other autoimmune disease, okay, what actually happen in pregnancy? Pregnancy is an immunosuppressive state and also a prothrombotic state. So at this point, we don't need to know the prothrombotic state. We need to know that in pregnancy there is immunosuppression, and SLE is one type of autoimmune disease. So we will expect that in pregnancy, the activities of SLE will decrease, but unfortunately, it's not. In SLE, in pregnancy, SLE will increase. The activity will SLE will increase, and it's actually exception regarding other autoimmune diseases like rheumatoid arthritis, systemic sclerosis, other autoimmune disease. Their activity will decrease during pregnancy, but in pregnancy, SLE activity of SLE will increase. Okay, before going to the next question, can anybody please tell me what will happen if a mother is pregnant? If a mother is pregnant and she is suffering from SLE, and somehow his SLE is not managing well or properly, what will happen to her child, and which antibody is responsible for that condition? Can anybody please tell me? You can drop your answer in the chat box. Anyone? Anti-arrow, yes, anti-arrow and anti-LA antibody. It is actually, yeah, miscarriage happen, but most important actually clinical outcome or clinical consequence is heart block. Okay, so I'm going to that slide. Okay, which one of the following tests is more specific for SLE? I think everyone is out of the answer. That is anti-DS DNA. Most sensitive and most common is ANA, most specific anti-DS DNA and anti-SM. Okay, what is the conception behind most sensitive and most specific? Most sensitive means like girls are more sensitive. Okay, like even some boys are more sensitive. Just you will touch him and he or she will read, oh my god, I'm getting so much pain. That is sensitive. So when there is damage of a little bit tissue, a chemical marker, maybe that is an antibody or antigen or any other thing, when there is a minimal damage of tissue and that chemical mediator is eventually appearing in the blood and you can detect in that particular chemical matter by laboratory investigation, that is the most sensitive marker. Okay, but that is not most common. Like you are the only boy in a class and you have 50 female classmates and all of them are really sensitive. Whenever you are pinching them, they are reacting. Everyone is reacting. Okay, just think what is the most common thing that everyone is reacting. So NA is that like thing that everyone is reacting to your pinching. So NA is releasing from damaged tissue in almost every autoimmune disease like rheumatoid arthritis, systemic sclerosis, polymyositis, dermatomyositis, and SLE. But they are not specific because every girl is reacting to your pinch. Okay, so which one is the specificity? Like your own friend is make a sound ah. Okay, when you're pinching her, she's making sound ah, but not other girls are making that sound. That is the most specific because only one person is making that sound. So only anti-DS DNA and anti-SM, anti-SM antibody, you will find that in SLE. So that when there is an autoimmune process in your body, like rheumatoid arthritis or SLE or any other disease, you will get ANA. That is most sensitive and most common. Why it is most sensitive? Because it is releasing in the blood when there is minimal tissue damage because of the autoimmune process. But in case of SLE, you will get anti-DS DNA or anti-Smith antibody. But if it is rheumatoid arthritis, there will be anti-CCP. Okay, there will be anti-CCP. So depending upon which type of autoimmune process is going on your body, the body reacts regarding that autoimmune process. Like if you define rheumatoid arthritis, it has one type of autoimmune process. SLE, that is also autoimmune disorder, but that is another type of autoimmune process. So the body will react according to their autoimmune process and they will produce more specific antibodies. So anti-DS DNA and anti-SM is for SLE. Please remember this. I have discussing this question for long because I have found this question has come for a long period of time. Okay. SLE antibodies associated with congenital heart block, that is anti-RO. Okay, anti-RO antibody. Okay, first sign of SLE reactivation activity is C4 level falling. Actually, during the active part of disease of SLE, both are low, both C3 and C4. But if you consider that which one fall first, that is C4. During active disease, you will get high ESR but normal CRP. High CRP indicates underlying infection. Now the treatment. If SLE has a great tendency to involve the kidney and usually it produces DPGN, okay, diffuse proliferative glomerulonephritis. Actually, when the SLE involve the kidney, we define it as lupus nephritis. It has several stages, but most common is DPGN. Okay, you don't have to go to that further, but if there is SLE plus renal involvement, your drug of choice will be mycophenolate mofetil. But if there is SLE but no renal involvement, like the clinical scenario is like that, the patient presenting to you with facial rash which aggravates on sun exposure, also she has multiple oral ulcer, she also complained of a little bit of joint pain. What is your diagnosis? Your diagnosis is SLE. And first, if you want to diagnose idiopathic SLE, you have to exclude drug history too. So your treatment is hydroxychloroquine. And in case of drug-induced SLE, you have to just omit that drug. Just try to give alternative drug. Okay, I'm getting a little bit problem with the chat section. Okay. Dr. Shawanisha asked, so if I am supposed to do a single investigation, I have to do dsDNA, right? Actually, not single investigation. They will ask like this: how you will confirm the diagnosis? How you will confirm the diagnosis? Then anti-dsDNA or anti-SMIP, or what is the most specific antibody? Then what you will do? You can do anti-dsDNA and anti-SMIP. But if they ask like, you are suspecting the patient is suffering from SLE or the patient is suffering from an autoimmune disease, what will be your next step? Okay, what will be the next step? Like a patient is suffering from joint pain, a little bit rash on his body, and also she has oral ulcer. The GP, okay, the GP is a little bit confused whether it is SLE or rheumatoid arthritis or any other autoimmune disease. But still the GP is suspecting, the GP is not confirmed whether it is autoimmune disease or not. So as a doctor, if you want to confirm it whether it is autoimmune disease or not, initially you can do ANA. Initially you can do ANA. Okay, then you can go specifically for, if you suspect rheumatoid arthritis, you can do anti-CCP, you can do anti-dsDNA, you can do anti-SMIP. Okay, but ANA will confirm whether it is autoimmune or not. Then your next step. Usually they don't give this question. They are like, what will be your initial approach? Usually they give what is the most common antibody. Sometimes they give a scenario of rheumatoid arthritis too. Sometimes they'll give the patient is suffering from morning stiffness, a little bit joint pain, and the eyes are dry, because all the autoimmune diseases has a little bit extraarticular manifestation. Maybe they will present with a little bit fluency, pericarditis, eye problem. So the patient has problem with the joint pain, joint stiffness, and little bit dry eyes. How you will confirm the diagnosis? They will ask like this. So when they're asking, or like when they're directing you towards an autoimmune condition, then first you have to think it might be rheumatoid arthritis or it might be SLE. Then you have to think, okay, if it is SLE, then go for anti-DS, and if it is rheumatoid, then go for anti-CCP, because even rheumatoid factor can be positive in many more autoimmune diseases. So rheumatoid factor is not the specific. Okay, and for SLE, AN is not specific too. For SLE, AN is the most common. Even rheumatoid arthritis, you will get AN. That's it. Okay, I have to take too much time on first question. Going to the second question. Okay, ACAA. So Here you guys can see tender angular lymphadenopathy and a painful ulcer. Okay. Someone said C. Don't worry. And also yes, 2 candidates, and others are silent. Don't want to take risks. It's okay. First of all, in syphilis, everything is painless. Painless. Okay, syphilis start with S and painless. So the answer is chancre. But why the answer is chancre? Actually, this is a very important, and I have made this chart during my MRC pattern preparation. I wish I could make this. I could make this chart during my PLAB one, so everything will be very easy. First of all, whenever this chart is useful to solve question of PLAB, but not to diagnose patient actually.